Please come up, continue the controversy, but we're going to go bigger. So go big, or go
That's why
How about full percutaneous MCS? Go for it.
Thank you, and thanks for inviting me to chat. This has been a fantastic meeting so far. I'm Monty Daneshmand, and these are my... How do I advance the slide? These are my disclosures, but I also want to have a couple of disclaimers. You know, my talk is going to be basically a faith-based talk. There's going to be no data. I'm going to talk about a case and then some of my insane musings, and so please don't take me too seriously. You know, I think I have this conversation with the residents all the time when we're talking about this. I ask them, you know, when did Noah build the ark? And I think, you know, everybody can say, you know, it's nice to try to do things exactly at the right time, but sometimes you need to stop, prepare for catastrophe, and really going big is what allows you to prepare for catastrophe. You know, I think the benefits of rapid full support, well, it stops the death spiral. You know, we were talking about that in one of the talks earlier, that there is a hemodynamic spiral. There's a whole biochemical set of pathways that happen with tissue hypoxia. Well, at some point, you know, that becomes no longer reversible. I think all of us here who deal with shock have patients who we've put on support, and we've put on maximal support, and no matter how fast we make the blood spin round and around in their body, we can't seem to correct the physiologic problem and get them to a better state. Well, I think if we intervene early on these people, prevent them from crossing this so far, as of today, undocumented threshold, restoring an aerobic metabolism, we can improve survival in those patients. I think, you know, the other nice thing is that, you know, 20 years ago, we didn't really have good, safe tools to do this. We didn't have the ability to put people on support quickly. We didn't have eCPR programs. We didn't have a Lucas device. We didn't have the Impella 5.5, the Impella CP. And now we have a cadre of tools that allow us to very safely, it's no longer going to the OR and putting 2 PVADs in, which is what I used to do back in the day. It's, you know, we can do things peripherally, percutaneously with relatively hemocompatible devices, and I think that really pushes forward the idea of, you know, early support, full support, get them off of the toxins. You know, we now know epinephrine is bad for you, which I think every heart failure surgeon in the room was having chest pain when they heard that, because we use it like it's a vitamin, you know, and so, you know, these are the things that allow us to do that. So I'd like to just, if you please, just let me go through a quick case and, you know, talk about what we did and the outcomes. And this is really, again, a faith-based talk. It's stories. So this was a 64-year-old man. He was admitted to the CICU with acute on chronic biventricular failure, really LV failure. And he had the starts of some cardiogenic shock, some irritability in rhythm. To complicate things, he was best friends with the health system CEO. So I got a phone call from the health system CEO that he's been admitted to the hospital. I said, oh, that's great. You know, we'll see what we can sort out. And the next morning, he VT arrests. They get ROSC, and they go to the cath lab, and they get an Impella CP to try to support him. And so now the question you got to ask, well, you know, he's had ROSC, he just had an arrest, he's relatively stable, still on some inotropes, on some mechanical circulatory support. And you guys just said, well, what do we do now? So option one is we can try to limp along, see if, you know, his kidneys have taken a big hit, see if there's other things going on. Or you can say, you know what, I'm going to remove the speed at which blood is going around in the body as an equation and let his body and let his physiology recover. And so at Emory, our choice and our preference is to do that. And so we took him to the operating room. We did ultrasound-guided percutaneous ECMO cannulation. He got an 18 femflex in the common femoral artery on the left. He got an 8 French biomedicus cannula in the SFA. I like to do that because I've noticed just using a regular sheath doesn't really provide you that much flow. You get 100 to 150 cc's a minute. You're limited by that stopcock, and this is a nice 1/4-inch connector. And he got a cannula in the common femoral vein. Now, my personal bias is nobody should nobody should ever have an Impella CP longer than it takes to do a PCI. And so I removed that device, cut down on the axillary artery, and put in an Impella 5.5. It's a surgical exposure. You get the axillary artery out. You sew a graft onto there. And the really nice thing is actually you can leave them on support with the CP, and you can get both devices in pretty easily. We get the wire down. Sometimes the wire can get a little hung up, but usually the device is stenting open the aortic valve so nicely that even a heart failure surgeon can cross the valve. So we get the wire in. We exchange it over a catheter for the Impella wire, and then we go ahead and deliver the device. One of the things here, I think you'll see the device will struggle to go in a little bit. That was just in this particular case because we weren't holding good back tension on the wire as we were coming in. This was, I try to teach the trainees all the time, don't let the wire go forward because then it goes limp. But once we revisited that, both devices popped in across the valve very nicely and easily, and you'll see that here. We put a little back tension, and now you have both devices across the valve. You pull the wire out, you turn them both on, and then you can, under visualization, very easily remove the other one, put it into the aorta, and now the patient is fully supported. And the advantage of this, similar to what Dr. Schrager says, is now you have an option to do something with the patient. You can wean them off ECMO. So we took him to the ICU. He was extubated. He was maintained on ECMO and Impella. We took liters of fluid off of him. Immediately, all of these patients immediately start making urine and taking volume off. We slowly, over the course of several days, weaned him off ECMO to just Impella support, proving that probably his right heart can tolerate being in an LVAD situation, and we can make him hemodynamically better. He was taken to the OR, and we actually removed the ECMO cannulas percutaneously. This is something that we've started doing. We've been able to get rid of the vast majority of our groin-related infection complications. 4 or 5 days, 7, 10 days, doesn't matter. We stick a needle in the ECMO cannula, pass the wire up, remove the cannula, and we use the Monta device to close up to, I recently closed the 22 French arterial hole with that. I don't ever recommend putting in an ECMO with the 22 French arterial cannula. It was done at another place. And then shortly after being on Impella, he got his HeartMate 3. Of course, as you could predict, a sick guy going to the OR getting a HeartMate 3. He did have some RV dysfunction. He got a RVAD at that point, and then that was removed peripherally. And then he was listed for transplant and transplanted. And now, he's alive and doing well because we intervened quickly. We didn't let him go into renal failure. We didn't let him go into liver failure and start the death spiral. Thank you for your time.
Well done, Danny. Well done. You got 5 major procedures out of one patient and never had to worry about timing.
That's right.
So, let me ask you about coordination. I think the big thing with this is you really have to have the team approach. And we've all talked about the shock team and the whole thing. What are your thoughts?
Yeah, you can't do this without a team. It's a lot of work for 1 or 2 or 3 people to do. This was a person whose care was passed on multiple levels. We had our heart failure cardiology team, our CICU team, our cardiothoracic ICU team, and they were just very seamlessly passing the baton amongst each other. And I think you can't do it without a big team.
Right. So, Dr. Baniasi.
Would this case go for Impella 5.5 plus Protect Duo from the beginning? And you could keep Protect Duo after putting the LVAD in? That's number one. Number two, what is the risk of arrhythmia with placing Impella in a patient who was arrhythmogenic before? Because we know that Impella, if not position is okay, is adding also to the arrhythmia. Do you watch that and how you manage that?
Yeah, I think those are both fantastic points. The first one, he could definitely be supported with a Impella and Protect in some situations. In this particular case, despite being on the Impella CP, he was still pretty sick, and I was concerned that I wouldn't really be able to have the time. It takes a good hour and a half to get the 5.5 in, and then you'd have to get a Protect in on top of that. You can get somebody on ECMO in 5 minutes, and so we put him on ECMO to to let me relax when we're trying to get the Impella in. The other thing, I think, if you rush when you're trying to put an Impella 5.5 in axillary, you're going to have bleeding, and it's a much better operation done in a controlled fashion. With regards to, I've done the other strategy, and I think that's a fantastic strategy. What was your second question?
The arrhythmia we saw in...
Arrhythmia.
Yeah, Impella 5.5 is a great device. It's a game changer from
Yeah.
my point of view. But we still see arrhythmias because of the positioning.
Yeah.
And, yeah.
So I think, a couple things. One, there's no pigtail, which helps. Two, I think I agree with you. This device needs to be positioned differently. I don't put this device in the true apex. And we now have patients, and we're working on submitting this for publication. We have patients whom we've supported 6 months with a single Impella 5.5 without any problems. The key here, I think, is you have to position this along the septum, as close to the septum as we can. We look at it both in long axis on TE and in short axis, not by the true apex, but rather along the septum coaxial with the aortic valve.
The problem is repositioning. You put that in the right position, or I'm not now doubting that, but later on you see if you have patients 6 months, I have patient 38 days, and you see that the position is changing, and sometimes if you try to change, that's flipping back to the same position. Still, we're struggling with keeping that in.
This is with axillary 5.5?
Yes, sir.
Oh. We haven't had a similar experience. One of the things we do actually is once it's positioned, we take a really a big stitch and we put it around the repositioning sheath, so then nobody can reposition it. But initially in our experience, there were some people who were very excited getting their ultrasound out and they wanted to play with this thing. So we made it so that nobody can move it, and I think that's helped a little bit.
Before we move on, let me just ask you a question. So most unloading protocols call for a flow out of the LV into the aorta of about 1.5 liters. They kind of start with that. You're loaded for bear there with a 5. What's your protocol there, and can you explain why you wanted that 5 in there?
Yeah, I think so. You can pretty safely and very easily get around 1.5, 2 liters a minute. And that's exactly what we shoot for, is we want to have a minimum of 1.5 or 2 liters a minute through the Impella 5.5. You just do it at P4 as opposed to P7. And it works very well, and it's very nice. I mean, we've trended these...
lower RPMs is
Correct.
Okay.
Yeah. And it's very hemocompatible. I mean, we don't have, at the P4 level, we've had nobody with an elevated plasma-free hemoglobin that's even detectable. The lowest we can detect is 30 in our institution, and at P4, we've never been able to detect that for anything.
I mean, I think that's the strategy, is to have the robust support if needed, and then you dial it down. But what about volume over time for long patients and antithrombotics?
Yeah, so we try to take volume off as much as we can, because I think that helps the RV. With regards to anticoagulation, we have a gradual increase in anticoagulation because we have a surgical site. So we start with no anticoagulation initially. If they're not bleeding in their axillary site, we start heparin in the purge. And then if they're not bleeding with that, after 4 to 6 hours, we start parenteral heparin. If their plasma-free hemoglobins are low, we follow anti-10As at Emory. I've also done PTTs. But if they're not bleeding and they're not having elevated plasma-free hemoglobins, we shoot for an anti-10A of 0.3 to 0.5. If they are having some plasma-free hemoglobin, then we increase that to 0.5 to 0.7.
That's a very elegant way to do things.
What about antiplatelet in that setting?
So
for long term,
we don't use routine antiplatelets aside from a baby aspirin, and I don't know why we use a baby aspirin. We just, I think we do it the same reason we use it in HeartMate 3. I don't know why we use it, we just do.
Sure.
If they've had coronary intervention, as part of their treatment, we'll use IV cangrelor because we can turn it on and off to deal with bleeding and other procedures. And once we're happy that they're not going to get another procedure, then we use Plavix or Prasugrel.
Got it. All right, we want to thank you.